This recording will go over urothelial cancer and bladder trauma. Urothelial cancers are malignant tumors of the urothelium, which is the lining of transitional cells in the kidneys, renal pelvis, ureters, urinary bladder, and urethra. Most urothelial cancers occur in the bladder, and the term bladder cancer describes this condition. Tumors confined to the bladder mucosa are treated by simple excision, whereas those that are deeper but not into the muscle layer are treated with excision plus intravesical or inside the bladder chemotherapy. Cancer that has spread deeper into the bladder muscle layer is treated with more extensive surgery, often a radical cystectomy or removal of the bladder and surrounding tissue, with urinary diversion. Chemotherapy and radiation therapy are used in addition to surgery. If untreated, the tumor invades surrounding tissues, spreads to distant sites, and ultimately leads to death. Exposure to toxins such as gasoline and diesel fuel, as well as to chemicals used in hair dyes and in rubber, paint, electrical cable, and textile industries increases the risk for bladder cancer. The greatest risk factor for bladder cancer is tobacco use. Many adults believe that tobacco use is associated with cancers only of organs that come into direct contact with it, such as the lungs. However, many compounds of tobacco enter the bloodstream and affect other organs, such as the bladder. Therefore, encourage everyone who smokes to quit and non-smokers not to start. Just as important, encourage anyone who comes into contact with dry, liquid, or gaseous chemicals to take precautions. In regards to assessment, ask about active or passive exposure to cigarette smoke. Ask about hobbies and occupations and chemicals that the patient may be exposed to. Ask about changes in urine habits or the presence of abdominal symptoms. Assess skin color and nutrition status. Examine urine for color and clarity, and assess the psychosocial status and coping mechanisms of the patient. Bladder wash specimens and bladder biopsies are the most specific tests for cancers. Cystoscopy is usually performed to evaluate painless hematuria. A biopsy of the visible bladder tumor can be performed during cystoscopy. Therapy for the patient with bladder cancer usually begins with surgical removal of the tumor for diagnosis and staging of disease. For tumors extending beyond the mucosa, surgery is followed by intravesical, chemotherapy, or immunotherapy. High-grade or recurrent tumors are treated with more radical surgery plus intravesical chemotherapy, radiotherapy, or both. In terms of non-surgical management, prophylactic immunotherapy with intravesical instillation of Bacille Calmette-Guerin, or BCG, a live virus compound, is used to prevent tumor recurrence of superficial cancers. Usually, the agent is instilled in an outpatient cancer clinic and allowed to dwell in the bladder for a specified length of time, usually 2 hours. When the patient urinates, live virus is excreted in the urine. Teach patients receiving this treatment to prevent contact of the live virus with other members of the household by not sharing a toilet with others for at least 24 hours after instillation. Instruct men to urinate while sitting down to avoid splashing the urine. After 24 hours, the toilet should be completely cleansed using a solution of 10% liquid bleach. If only one toilet is available in the household, teach the patient to flush the toilet after each use, followed by adding 1 cup of undiluted bleach to the bowl of water. The bowl is then flushed again after 15 minutes, and the seat and flat surfaces of the toilet are wiped with a cloth containing a solution of 10% liquid bleach. Instruct the patient to wear gloves during the cleaning and to dispose of the cloth after sealing it in a plastic bag. Underwear or other clothing that has come in contact with the urine during the immediate 24 hours after installation should be washed separate from other clothing in a solution of 10% liquid bleach. Sexual intercourse is avoided for 24 hours after the installation. The type of surgery for bladder cancer depends on the type and stage of the cancer and the patient's general health. Complete bladder removal, or cystectomy, with additional removal of surrounding muscle and tissue offers the best chance of a cure for large invasive bladder cancers. Specific patient education depends on the type and extent of the planned surgical procedure. Coordinate education before surgery with the patient, surgeon, and endostomal therapist or ostomy nurse. Discuss the type of planned urinary diversion and the selection of a site for a stoma. Including the patient in this planning improves the chances for the patient to have a positive attitude about body image and a positive self-image. Different types of urinary diversion procedures are seen on Figure 66-4. Ureterostomies divert urine directly to the skin surface through a ureteral skin opening or stoma. After ureterostomy, the patient must wear a pouch. Conduits collect urine in a portion of the intestine, which is then opened onto the skin surface as a stoma. After the creation of a conduit, the patient must wear a pouch. Ileoreservoirs divert urine into a surgically created pouch or pocket that functions as a bladder. The stoma is continent, and the patient removes urine by regularly self-catheterization. Sigmoidostomies divert urine to the large intestine, so no stoma is required. The patient excretes urine with bowel movements, and bowel incontinence may result. Ileoreservoirs, or Cox pouches, or neobladder, as they are known, have no sensation of bladder fullness because sensory nerves are not attached. As a result, the patient will need to learn new cues to void, such as prescribed times or noticing a feeling of neobladder pressure. Different types of drains and nephrostomy catheters are used, sometimes on a temporary basis, to drain urine from the kidney. Please review the care coordination and transition management portion on your own. Bladder trauma can be caused by penetrating or blunt injury to the lower abdomen. Penetrating injury may occur by stabbing, gunshot wound, or other trauma in which objects pierce the abdominal wall. A fractured pelvis with puncture of the bladder by bone fragments is the most common cause of bladder trauma. It also may result from sexual assault. Blunt trauma compresses the abdominal wall and the bladder. A seat belt may compress the bladder hard enough to cause injury, especially when the bladder is full or distended. Patients with a penetrating bladder wound often have anuria or hematuria. In the ED, initial assessment includes inspection of the urinary meatus for blood. Bladder trauma, other than a simple contusion, requires surgical intervention. Surgical interventions include repairing the bladder wall and peritoneal membrane. Patients with an anterior bladder wall injury usually have a Penrose drain and a Foley catheter in place after surgery. Those with posterior bladder wall injury may have a Penrose drain and Foley or a suprapubic catheter after surgery. Psychosocial support is critical for patients who have sustained traumatic injuries. Refer them to counseling resources to help them deal with their psychosocial issues. Please pause the video to read the questions and pick out your answer, and then resume the video to hear if you are correct. For question 1, the correct answer is A. The most common cause of urethritis in men is STIs. For question 2, the correct answer is A. Anyone can form a kidney stone, yet they are more common in males, Caucasians, patients who are dehydrated, those who are very overweight, those who have had kidney infections, those with family members with kidney stones, and those who have had kidney stones before. Question 3. The correct answer is C. Catheters are the most common factor that place patients at risk for UTIs in the hospital setting. Within 48 hours of catheter insertion, bacterial colonization begins. Thus, the goal is to remove the catheter within 48 weeks after placement, whenever clinically possible. About 50% of patients with indwelling catheters become infected within 1 week of catheter insertion.